Good morning, everybody. It's a pleasure to be virtually with you. I would love to be physically with you, but I mean, it's quite far. Hope next time. And I've been invited to talk about pancreatic tumor imaging. When dealing with pancreatic tumors, we can just distinguishing in solid and cystic tumors. Hypovascular tumors are mostly represented by pancreatic ductal adenocarcinoma. Hypervascular lesions are mostly represented by neuroendocrine tumors, and cystic tumors, either benign, such as serous, uh, borderline or malignant, such as mucinous, SPEN, and IPMN. We have two main imaging techniques to analyze the pancreatic lesions. So that means CT and MRI. State-of-art CT is represented by multi-detector CT with iterative reconstruction, dual energy or spectral imaging. Very useful in the pancreatic imaging is low kV protocol. The timing should be correct in the pancreatic phase. That means a little bit later than arterial phase. And high iodine load is an important technique in order to have a better contrast to noise signal between the tumor and the pancreatic parenchyma. Uh, how dual energy CT can be implemented in pancreatic imaging? When we use dual energy CT, that means we can change the energy levels, and usually the 70 to 52 kiloelectron volts is the best energy in order to detect the best contrast between the lesions and the pancreas, so we can better visualize the small lesions. And this is useful for pancreatic adenocarcinoma, but even with low energy, we increase the signal from the contrast media, so we can see very well also the neuroendocrine tumors. As you can see here, this was quite old paper, but still valid. If we lower the energy from 140 kV to 80 kV, we significantly increase the tumor conspicuity in comparison to the surrounding pancreatic parenchyma. So that means when we use CT, try to work with the low kV protocols. Moreover, if we use a high iodine concentration with a low KBP, will lead to higher contrast enhancement. That means if we use, for example, Yomapro 400, we can get a better enhancement of the vessels and the parenchyma, but most important, we have a better contrast between the lesions and the surrounding parenchyma. So, for example, in this case, the effect of tube voltage and iodine load was much better, the tumor delineation, when we use the protocol B and A in comparison to standard. The standard was 100 kV, A and B was 80 kV. The B is with a higher iodine load, and the higher iodine load gave the highest contrast to noise ratio between the lesion and the parenchyma. So in conclusion, low kV, high iodine load protocols improves tumor delineation and contrast to noise ratio, leading to higher tumor conspicuity compared to standard protocol. MR, the state of MR is the protocol is quite simple, but very sensitive and specific. That means just anatomy, diffusion weight imaging, T1 FAT-SAT best for the signal of the pancreas, and of course dynamic imaging and MRCP without or sometimes also with secretin. Why hasty 2? Hasty 2 is very fast, 1 second for each image. It is very well performed also in uncooperative patients. Very high sensitivity for cystic lesions, and in case of solid lesions, it's just useful for the anatomy. But for the anatomy, in order we can see a comprehensive view of the upper abdomen. T1 FAT-SAT, it's the more sensitive technique for the detection of pancreatic lesions. Normal pancreas usually has a bright signal similar to the liver, And when we see a lesion in the pancreas, whichever is the lesions, we always see a change of signal, and the pancreas becomes hypointense, high sensitivity, low specificity. Here there's a tumor. This is the chronic obstructive pancreatitis upstream the tumors, but the signal is the same. So we just to see the lesion, and then we use DVI and dynamic imaging in order to have a better characterization of the lesion. Dynamic imaging is important because it allows us to distinguish between hypovascular lesions such as pancreatic ductal adenocarcinoma or hypervascular lesions such as neuroendocrine tumors. So very good, very good dynamic imaging is important for detection and for characterization. Do not forget that in case of suspicious of pancreatic cancer, we need to explore very well also the liver, because MRI is a mandatory technique after local staging with the multi-detector CT in order to exclude the presence of liver metastasis. That means we can use liver-specific MR contrast agents such as multi-hands, because in this case we have very good dynamic imaging, and we can also explore the liver in the hepatobiliary phase in order to detect very small metastases. DY, it's nowadays it's a very important tool because it's used in not only to detect but also to characterize the lesion and to follow up many lesions such as IPMN or other lesions. Because in such case, it's a very fast sequences. Nowadays, we can have upper abdomen DVI in less than 2 minutes with the new sequences. That means it's in a standard protocol does not allow too much time to be performed. And finally, MRCP. And in my practice, I used to perform MRCP after the injection of contrast media. So if in my protocol I have to inject the contrast media, I perform the MRCP after. Why? Because if we inject the contrast media and we wait 3 minutes, then we perform MRCP, the contrast media is in the vessels and in the interstitium, and the T2 star effect of gadolinium cause the loss of signal by the dust tissues. So we don't see anymore the vessel, as we can see here before the contrast media. These are hepatic veins which disappear after the contrast media. We see much better the biliary ducts, and we also see much better the Wirsung duct, as you can see here, the same patient before after, because also the pancreatic parenchyma lose the signal in the background parenchyma because of the presence of the gadolinium in the interstitium. So we see better the Wirsung duct, which does not contains gadolinium. I remember you can perform this trick only if you use multians or other vascular interstitial contrast media. Don't use it after Primovist, because Primovist it goes very fast in the biliary ducts. So if you perform MRCP after Primovist, you will lose the biliary ducts. So what is the role of CT versus MRI in management of solid hypovascular pancreatic ductal adenocarcinoma? MRI has the higher sensitivity in the detection of small iso to iso-intense or iso-dense pancreatic ductal carcinoma. Multi-detector CT shows better performance in local staging, especially in the relationship between the tumors and the peritumoral vessels. MRI has a better sensitivity in detection of small liver metastases, and you have to use diffusion weighted imaging and liver-specific MR contrast agents such as multians. For example, these patients, he has jaundice, and this is the CT, and we can only badly appreciate some hypodense lesion here, but if we perform MRI, and you already see with the diffusion with imaging small bright lesions here, much better seen on T1 facet, this tumor, this the pancreatic parenchyma still not affected by chronic obstructive pancreatitis, so you can clearly see the lesion even without the contrast agent. But for local staging, it's important the relationship between the tumor and the surrounding vessels. As a rule of thumb, I remember you that we talk about abutment when the contact is less than 180 degrees versus encasement when the relationship is more than 180 degrees. So in this case, we are almost sure there is involvement of the vessels. In this case, the vessels are less likely to be involved by the tumors. So in local staging, multi-detector CT is the best imaging technique because it has a very good vessel depiction, a very high spatial resolution, which allows us to perform multiplanar reconstruction with a very uh, high quality of the images. So we can clearly state there's no involvement. We can state there is a more than 2 centimeter involvement of the mesenteric veins in the portal tract. That allows it's difficult for the surgeon to be resected. And we can see also teardrop changes of the superior mesenteric artery, as well as a complete involvement of the superior mesenteric vein, sorry, and as well as an important involvement of the superior mesenteric artery. So resectable, borderline resectable, border resectable, unresectable. On the contrary, MRI is the best imaging technique to detect liver metastasis. Small liver metastasis usually, sometimes, especially if the patient is a jaundice, obstructive jaundice, are harder to be seen with CT. Like in this patient, it was very difficult to see any lesions, but look at with diffusion weight imaging how many lesions were present in this patient. So DY is a best technique, and if with DY, if you use liver-specific and MAC contrast agents, you can better appreciate the small metastasis, hardly to be seen during dynamic imaging, but in the liver-specific and MAC contrast agents, 2 hours after the injection of multians, we clearly see these small lesions, which was related to a small metastasis. MRI is also very useful to make a difference in diagnosis in small hepatic lesions. Do not forget that even in oncological patients, small lesions not always are metastases. Like in this patient, this patient had a total pancreasectomy for a diffuse involvement of the pancreas by pancreatic carcinoma, and on CT there was these small lesions, clearly not characterizable with CT. With MRI, we see these lesions showing a loss of signal on DY, bright on LDC, and at the end, if we wait minutes and minutes, there is a complete fill-in of the lesions. So this was a small hemangioma with some fibrotic changes in the center, which prevent an early enhancement. But if we wait minutes and minutes, we can do it. This was done with multians because multians allows us to have a very good delayed hepatic phase. So as a whole, how we manage patient with pancreatic cancer after multi-detector CT, if the patient lesion is resectable, borderline locally advanced, or metastatic. In case of metastatic, of course, we have best supported care of palliative chemotherapy, but in case of the patient is still potentially resectable, we have to perform MRI in order to exclude the presence of a small hepatic metastasis. In this case, once again, they go to best supported care. In case of a resectable, borderline locally advanced after MRI, if patient is a high risk, depending on the amount of CA 19.9 or the size of the lesion, there is no high risk upfront surgery. High risk, the PET is useful, and then if it is negative, go to upfront surgery. Borderline resectable, high risk, no risk. No risk, neoadjuvant therapy and follow-up with CT and MRI. High risk with PET in order to exclude small metastases. Locally advanced requires PET because PET is an important tool in the follow-up because the decrease of SUV, standard uptake value, is an important finding to state if the patient is resectable or not. And staging laparoscopy should be also performed in this patient. This is after a multidisciplinary discussion. Another important tool is imaging after neoadjuvant therapy. Just a brief review. Remember, it's very difficult with imaging in us to assess the response to therapy. So what we have to deal is the lack of progression. If after neoadjuvant therapy there's no progression, the patient should be sent to resection after multidisciplinary discussion, especially if there is a solid tissue around the vessels that becomes more too hollow, so less dense after around the vessels. This assigns that in most of the cases we will have an R0 resection. And once again, after that, MRI of the liver in doubtful lesions of the liver. So, very easily, pre-neoadjuvant therapy, after neoadjuvant therapy, solid lesions tissue around the vessel, hollow signs. This patient was an R0 resection. Solid hypervascular lesions, we deal with the neuroendocrine tumor. So most of these lesions are hypervascular, so thus a very good arterial phase is important for the diagnosis. Usually small nets tend to be homogeneous. Larger lesions demonstrate heterogeneous enhancement, cystic degeneration, necrosis, fibrosis, and calcification. And typically, neuroendocrine neoplasm are characterized by clearly restricted diffusion due to the high cellularity. So, dynamic imaging, iodine concentration is requested, very high iodine concentration is requested in order to have a good enhancement. High iodine concentration means high iodine delivery rates, and this increases the arterial phase, allows a better identification of hypervascular lesions, in this case for focal liver lesions, but also in case of pancreatic hypervascular lesions. And you can see here, sometimes the arterial phase is much more important on CT than in MRI. This patient has a small hypervascular lesion. It was an insulinoma, clearly seen after contrast enhanced ultrasound, clearly seen in the dynamic phase, in arterial phase, but badly seen with MRI, because in the arterial phase, also the rest of the pancreas shows a very high enhancement with MRI. So sometimes small lesions are difficult to be seen, and the only way to see them is with DVI, where they show the restricted diffusion. But of course, fusion imaging, especially between the T2 and the diffusion weight imaging, are very useful to detect even smaller lesions. In this case, it was a patient with MEN1, the multifocal neuroendocrine neoplasm. We clearly see the largest one in CT and in MRI, but there were even other smaller ones, and we can only see better with the diffusion weight imaging and the fusion imaging with T2 and DVI. Sometimes when the lesions are very small, we can only appreciate with a good diffusion weight imaging, like in this case, this was a G1 NAN. But do not forget that PNANs can lead to atypical features, and the most common atypical presentation include non-hypervascular PNANs, up to 49%. That means hypervascular PNANs, they can simulate a pancreatic ductal adenocarcinoma, or PNANs which show a progressive enhancement. But we can also have cystic PNANs on other more rare cases with the intravessel growth pattern or intraductal growth pattern. In this case, we have a reduction of the vascular network and increase of stroma, and this leads to this atypical dynamic behavior. Such as in this case, this was a hypovascular PNANs, not clearly seen in this patient, but we see very well on T1 facet, a black lesion, which shows a restricted diffusion, only a peripheral enhancement, and dilatation of the Wilson duct upstream. Dilatation of Wilson duct upstream in PNANs is usually a finding of more aggressive PNAN, and this was a G2 PNANs. Or in this case, this patient has a lesion in the body tail. The tail was completely atrophic due to the long-standing timing of these lesions, and as you can see here, this lesion shows a progressive enhancement from the arterial to the late phase, and this was a G1-10. And cystic plants. More often we see these atypical lesions, and whenever you see a cystic lesions with thick walls, restricted walls, enhancing walls, think about the cystic plants, like in this patient, which was a G1, PT2, N1 plant. MRI is very useful in the follow-up of plants. You know that the small plants, G1 plants, less than 2 centimeters, without symptoms should be follow-up. And of course, we follow up with MRI. After the first diagnosis of these patients, the small hypervascular lesions, we may follow up these patients for 4 years and no significant changes, but we see also the stenosis of the main pancreatic duct. And finally, cystic lesions of the pancreas. And the first classification we have to make is non-communicating or communicating with the main pancreatic duct. Because in the first case, we have some lesions, such as the most important mucinous lesions, serous lesions, span, and other more rare lesions. In case of a communicating system with the pancreatic duct, the most important lesion is IPMN. Of course, SPEN, solid pseudoelect neoplasm, are very well depicted, especially when they are large, either with CT or MRI, but usually these usually are young women, so it's better to perform MRI because there's no radiation exposure, and with MRI we can clearly see these are hemorrhagic changes of the lesion, which is one of the most typical pattern of this lesion. So this was resected, and this was the surgical specimen. Mucinous lesions, they are usually middle-aged women, so we have Spain in young women. Mucinous lesions is a middle-aged women, and they are mostly in the body tail of the pancreas. And you can see here the different technique, US, CT, MRI, and you can, with MRI, you can clearly see the enhancing septa of these large uniloculated lesions, and there is a typical pattern of a mucinous cystic neoplasm. And finally, serous cystadenoma, usually are older women of more than 50, 60 years old. There are different patterns of serous cystadenoma. The most typical is the microcystic pattern. Of course, we can appreciate with the CT, but with MRI, it's clearly seen, so we can make a correct diagnosis. This is a benign lesion, and the only way to make a follow-up is only to see if there is a chronic obstructive pancreatitis upstream the lesion. Sometimes serous cystadenoma have a solid pattern. So this patient arrived in our hospital with a CT performed elsewhere with a diagnosis of ACC. But we immediately saw the dilatation of the Wilson duct, so we performed the MRI, and the MRI clearly showed this was a serous cystadenoma with a solid pattern. That means a microcystic with a very well represented hypervascular stroma, leading to a wrong diagnosis in case we use technique not sensitive to the water, such as CT. But the diagnosis was made, the patient was quite old, so she was left unresected because she was already diabetic with no pain in this case. But sometimes it's difficult. So uniloculated cyst in the middle age in the tail, when we see in the tail, when you see uniloculated cyst, we think about mucocystic tumor. So we have to resect them. This was a serous tumor. Or a growing lesions, of course it was resected, middle-aged female, and this was a mucinous tumor. So sometimes it's difficult to make a differential diagnosis, so that's why MRI can be useful. And according to some papers, the ADC value of MRI can help us to distinguish between mucinous and serous lesions. As a rule of thumb, more than 3 is more typical of mucinous lesions, less than 3 is more typical of serous lesions. Such as in this case, this was a patient with a mucinous cystic neoplasm low grade. The lesion was increasing by the time but you can see here the ADC map was more than 3. This patient has a serious cystic neoplasm after diagnosis with endoscopic aspiration. The CAA was very low, and you can see here the ADC map was less than 3. If the lesion communicates with the main pancreatic duct, we are dealing with the IPMN. They are about 70% of all pancreatic cystic neoplasm. We have to distinguish as a first rule the main duct or mixed type IPMN from branch duct. The first one are more aggressive than the second one. So main duct dilatation, main duct IPMN, dilatation of the main duct without stenosis downstream. Branch duct, we see a communication with the main pancreatic duct. How can we manage this patient? There are many guidelines, many guidelines, but all guidelines, they try to triage depending on risk class. So we have a low risk, intermediate risk, that means worrisome features, or high risk, that means high risk stigma. Worrisome features are a relative indication for surgery, high risk stigma are absolute indication for surgery. In case of a selective approach, how can we manage this patient? So there are some main features which allows us to distinguish. And the problem is when we deal every day with many patients, this become more and more difficult. We have to perform more and more examinations. And what is important, even in case of enhancing nodules after endoscopic ultrasound with contrast, only 62% of these lesions were truly cancer at the pathological analysis. So can we use other technique, other biomarker? I think that DVI can be an important diagnostic tool to predict malignancy. According to different papers, diffusion restricted was the independent imaging parameters for prediction of malignancies in different papers. For example, this patient has a nodule inside, no DVI, no enhancement. This was just a mucin plug, and after 3 years, the nodule is unchanged. This patient has a branch duct IPMN, and after 4 months, there was a nodule here, which show enhancement and restriction diffusion not seen before. So this patient was invited to resection, but he came back 4 months later, July, January, and this is what happened. Large tumor with hepatic metastasis. Even small lesions should be followed up. Sometimes these lesions, which we do not see a clear communication with the pancreatic duct, so we call them indeterminate cysts. We need to follow up because these lesions, after 2 years, turn out to be a pancreatic cancer. So this was just a small retention cyst in a very early pancreatic cancer, which took almost 2 years to become clearly detectable. So in conclusion, CT and MRI are complementary technique in the management of pancreatic tumors. In case of a pancreatic ductal carcinoma, CT is standard for detection and it better use low QV protocol and high iodine load. MRI is better than CT for detection of small pancreatic carcinoma. CT is better than MRI in local staging. MRI is better than CT in searching for liver metastasis using DVI and liver-specific MR contrast agents. In case of neuroendocrine tumors, CT is better than MRI in detection of small neural lesions and low QV protocol and high iodine load again. MRI is better for atypical PNETs and follow-up. In case of cystic tumor, MRI is much better than CT for detection, differential diagnosis, and follow-up. And I thank you very much for your attention.